Residents. Yeah. I hope we all well. Yeah, since COVID is going up again, but hope we all well. So today again, we have Australian-Indonesian Glaucoma lecture series with two marvelous speakers. Yeah, of course we have Prof. Morgan here. So the first speaker will be a case presentations that will be presented by Dr. Mefina Aulia Mufidah. And then the second speaker would be our dearest teacher, Prof. Bill Dr. Morgans. I believe everybody have known him. Okay, Prof. Morgans. Yeah. So to save time, let me begin with this first speaker, who is Dr. Mufidah. Yeah. She's a resident from Department of Ophthalmology, Faculty of Medicine, University of Indonesia. So before begin, so if there are any question, please put your question in the chat box down here. Dr. Fida, please, that's time is yours.
Thank you, Prof. Vika. Let me start my presentation. Good evening, Professor, Doctor, and fellow residents. My name is Mefina Aulia Mufidah. Today, I would like to present a case entitled Glaucoma Progression. Female, 54 years old, first came to the clinic on January 2008 with a chief complaint of watery eyes. There was no blurry vision, no pain or headache. There was no history of narrowing of field of view, and she also had systemic disease of hypertension. Her visual acuity was over 7.5 in the right eye and 6/8.5 in the left eye, with elevated IOP 23 in the right eye and 24 in the left eye. Her anterior chamber was deep, and fundoscopy revealed round optic nerve head with distinct margin, with cup disc ratio 0.3 and to 0.4 in both eyes, and gonioscopy revealed open angle in both eyes. Octopus perimetry revealed normal visual field. And we assessed this patient with ocular hypertension of both eyes, and we plan to give timolol 2 times daily. In June 2008, 6 months later, she came with IOP 22 in the right eye and 24 in the left eye. Her cup disc ratio was enlarged to 0.4 to 0.4 in the right eye and 0.5 in the left eye. And the perimetry revealed still visual field was within normal limit, but we assessed this patient with primary open angle glaucoma, and we changed our medication to benzzolamide 3 times daily for both eyes. In August 2009, the patient came with IOP 20 in both eyes, and OCT examination revealed retinal nerve fiber layer within normal limit, and the Humphrey perimetry revealed visual field was still in normal limit. The VFI is still good, 99% on the left eye and 100% on the right eye. The pachymetry revealed 489 microns in the right eye and 486 in the left eye, and the adjustment in IOP was done, and the IOP for the right eye was and the left eye ranged between 24 to 25. We assessed this patient with still primary open angle glaucoma, and we plan to give the therapy timolol and benzzolamide for both eyes. And over the course of treatment, the IOP fluctuated to 22 and 20 in February 2010, and the therapy changed to latanoprus once daily. In May 2010, the IOP was still 21 and 22 for the right eye and for the left eye. And the cup disc ratio was still stable at 0.4 at the right eye, but there was enlarged the cup disc ratio was enlarged in the left eye to 0.5 to 0.6. The patient did the Humphrey perimetry test, and the test revealed in defect of the visual field in the pattern deviation, and also the glaucoma hemifield test revealed the outside normal limit in the right eye. However, in the left eye, we found the perimetry was within normal limit. We planned to add the medication, and the patient was then given Plus, which was the combination of timolol and latanoprus once daily for both eyes. In September 2012, the visual acuity was relatively stable and the IOP was 17 in both eyes. A perimetry examination was done and revealed in a normal visual field for both eyes. However, the pattern deviation in the right eye was revealed in 2 points below 1% and more than 3 points below 5%, but not in a contiguous pattern. We found the inconsistency in the results of the perimetry of the right eye. In 2013, the physical examination revealed in the cup-pitch ratio in the right eye became 0.6. But the OCT examination revealed the retinal nerve fiber layer was still in normal limit. And the Humphrey perimetry revealed also a normal visual field. In July 2013, the patient complained the redness and discomfort with thymal administration, and the medication was changed to latanoprost due to the complaint. In April 2015, the OCT examination revealed a normal thickness of the retinal fiber layer in both eyes. And the Humphrey examination showed glaucoma progression in the right eye. The visual field defect was recorded in the right eye with visual field index of 94% and the mean deviation of minus 4.20 decibel with p-value less than 0.5%. The glaucoma hemifield test revealed borderline. Here we also noticed that the CD ratio is enlarged to 0.7 to 0.8 from the physical examination, and the therapy changed to Trevetan once daily for both eyes. In April 2016, examination showed visual acuity and the IOP didn't change significantly. The OCT examination revealed thinning of the retinal nerve fiber layer at the nasal part of the right eye and also thinning of the retinal fiber layer at the temporal part of the left eye. There was no enlargement of the cup-pitch ratio from before, and the Humphrey perimetry revealed in defect of the right eye with and mean deviation of minus 3.31. The glaucoma hemifield test also revealed outside normal limit. There was also defect of visual field of the left eye with visual field index 96% and mean deviation of minus 5.37 decibel. However, this test had low test reliability because of the high fixation loss of the test. And then in October 2017, the intraocular pressure of the right eye was 10.7 and the left eye was 16.7. The cup-pitch ratio was 0.5 and 0.6 in the right eye and 0.7 and 0.8 in the left eye. The patient had the history of already given the medication Salatan once daily for both eyes, Azarga 3 times daily for both eyes, and Alphagan once daily for the left eye. And here we advise the patient to do the trabeculectomy with mitomycin C for the left eye. But however, the patient still hesitate to do this surgery, not until the January 2018. In January 2018, she finally won the surgery, and the postoperative day 1 revealed that the IOP was decreased to 8 in the left eye. And the postoperative therapy, the patient got the levofloxacin 6 times daily and prednisone acetate. And then we stopped the anti-glaucoma medication for the left eye, and we continue the Salatan and Azarga for the right eye. And here we did the OCT examination in November 2018, where the intraocular pressure here, in the right eye, the it was 16 and the left eye was 17. And the cup disc ratio was 0.6 to 0.7 in the right eye and 0.7 and 0.8 in the right. In the OCT examination, it revealed the thinning of retinal fiber layer at the nasal part at the right eye, but the cup disc ratio is still stable from the last OCT examination before. And the patient was then added the medication Salatan for the left eye, which had already undergone the trabeculotomy surgery. In July 2019, the physical examination showed visual acuity and the IOP was relatively stable. The visual acuity was 6/12 for the right eye and 6/15 for the left eye. And the IOP was 14 in the right eye and 10.3 in the left eye. The cup disc ratio was still stable and on no enlargement of the cup disc ratio. The OCT examination revealed no thinning of the retinal nerve fiber layer. And we found that the glaucoma progression in the left eye, we found the Humphrey perimetry revealed in defect in visual field in the inferior part with the VFI 94% and mean deviation of -7.9. The glaucoma hemifield test also revealed outside normal limit. And however, in the right eye, the visual field defect was not specific, with more than 1 points below 1% and more than 3 points below 5%, but not in a contiguous pattern. And then that's all for this presentation. I summarized this case that this patient has an enlargement of cup disc ratio over time, and the glaucoma progression itself can be detected by the clinical examination and also from the OCT and the perimetry. However, in this case, we didn't have any optic disc imaging in the earlier years of the follow-up. We only recorded the cup disc ratio by using the physical examination. And it is important for us to correlate changes in the visual field with those in the optic nerve. And progressive visual field may sometimes be seen in the absence of optic nerve changes. Thank you. That's all from me.
Thank you, Dr. Vida. It's very interesting case actually, but unfortunately that we don't have any photo footage for these patients. Okay, we saved the question regarding to this patient after the second speaker has been done. So we continue to the next speaker, to Prof. Dr. Morgan, with the title Optic Disc Examination Detection Changes. Please, Dr. Morgan, time is yours.
Thank you very much, Widya. Can everyone see the screen? Is that on the screen okay?
Yes. Yeah.
Good, thanks. Yeah, look, optic disc examination, progression, judgment, it's a huge topic. So what I thought I would do is simply talk about optic disc examination. I think that's a very important subject, something that we all do. And I'm going to start here. You'll notice that I'm showing you a weather chart. I tried to find a weather chart that had both Indonesia and Australia. This is not a very good one on the bottom left. But the reason for doing this was to show that pretty much every weather chart you look at has what we call isobars, or circles or partial circles with the air pressure being the same. And so you then get, when you have a storm, you get concentrations of higher pressure and you get kind of contour lines, if you like, of pressure. And the air flows from high pressure to low pressure because the pressure differences generate a force which basically pushes the air particles. So on the right-hand side, is from a textbook on weather patterns and understanding weather. And it's just illustrating the fact that pressure boundaries and pressure differentials create a force. Now, top left this is a schematic diagram I've drawn of a normal optic nerve head or optic disc. And in the normal optic nerve, the pressure is usually about 15 in the eye. And when you're sitting or standing, the pressure in the CSF or the brain fluid around the optic nerve is about 0. The pressure in the optic nerve behind the lamina cribrosa is a little bit higher than this. And in the dog, it's about 4, and it's probably about the same in the human. Now, the pressure differential is known to drop across the lamina cribrosa. And so the lamina cribrosa is almost indicating where the isobars are, so the positions of equal pressure, if you like, and also the gradient of pressure by how close the laminar beams are or how close those isobars are. So just want you to notice this, and to notice, for example, that the greatest pressure differential is in fact between the eye and the CSF space where the zeros are, rather than the eye and the optic nerve behind the lamina cribrosa. So let's talk about some more practical things. So this is a histological diagram of the optic nerve head in a patient who had severe glaucoma. And you can see that there's excavation, and also the black lines illustrate where the lamina cribrosa has been compressed, and it's sort of blown outwards towards the subarachnoid space, the hollow part where there's a fluid gap, basically. So in glaucoma, and down below is an OCT scan taken through the optic nerve showing excavation here, that E there, and you can see where the nerve tissue has been pushed backwards and the lamina cribrosa has been pushed quite a ways backwards as well. So the optic nerve in glaucoma is subject to forces that overwhelm the tissue strength. And that's probably the key differential between glaucoma and all of the other optic neuropathies. So if you get an ischemic optic neuropathy or a toxic optic neuropathy, then you don't get excavation. You will get loss of nerve fiber tissue, and you'll see a change on the OCT scan with loss of nerve fiber layer, but you won't see excavation. So it's a very important sign to look for in glaucoma. And it's due to this pressure differential effect acting across the lamina cribrosa, causing lamina cribrosa compression and distortion over time. And it occurs in the optic nerve because the lamina is the weakest part of the eyeball coat. So it's weaker than the sclera and weaker than the cornea. So that's why the lamina cribrosa bows outwards. So here's another schematic diagram, top left going from normal through to glaucoma, and you can see the lamina cribrosa has been pushed backwards and is compressed. So here's an example of a patient with moderately severe glaucoma. Vertical cup to disc ratio is probably 0.75, 0.8. They have some degree of myopia, and the distortion is not symmetrical. It's focal, and you'll see this from the OCT scan, where you can see, well, I've drawn in where I suspect the optic nerve subarachnoid space is, and the, if you like, the isobars or the lamina cribrosa connective tissue. And you can see that the maximum pressure gradient with the maximum forces are going to be pushing that tissue into the optic nerve space, the subarachnoid space. This gets changed if you have myopia, especially high myopia. And the problem with myopia is that it causes weakening of the sclera, particularly the sclera around the optic nerve. So here, this patient had a posterior staphyloma, and you can see bowing backwards of the sclera, and you can see a massively enlarged optic nerve subarachnoid space. It's very, very large, and you can actually see it on the OCT scan, which is quite rare. The lamina cribrosa is also compressed. So there's a whole lot of forces acting now. So the force can act, if you look to the left-hand side, can act through the optic nerve and push it backwards. But because the optic nerve subarachnoid space is so large and the sclera is so thin, it can act directly through the sclera. So you get this sort of altered distortion in myopia where there's often not so much excavation, although if you look hard, you'll often see a little bit of excavation. And that can sometimes make detecting or diagnosing glaucoma in the high myope quite difficult. So it pays to bear in mind what mechanically is happening to the nerve in these conditions. Now, I'm just going to talk a bit about standard optic nerve examination. So I know in Australia we have OCT scans everywhere, and we tend to get a bit lazy nowadays. It's often easier to look at the scan than to look at the optic nerve. But it's still very important to look at the optic nerve. So probably there's a few key features. One is to look at the optic disc size. So here, it's to identify the neuroretinal rim, and this is this part around here. And then to identify approximately what the vertical disc diameter is. Now, I've covered this really. So when you look at the optic nerve, one thing to look for is excavation, and this is just that previous OCT scan blown up. So not many of us use the direct ophthalmoscope anymore, but one of the handy things about the direct ophthalmoscope was that the small ring or the small aperture was about the average size of the average optic disc. So it was a reasonable way of noting whether the optic disc was smaller or larger than the small aperture or the small bright spot. And then you would have a gauge on whether the optic nerve was smaller or larger. And Dr. Philip House, who many of you know, published on this work actually back in 2005. Now, most of us would use an indirect lens at the slit lamp to look at the optic disc, and it's handy to know what your magnification is. So, for example, I tend to use a 60 diopter lens, and the magnification is about 0.9, which means the Volk lens, or rather the natural size, is about 10% less than the natural size is about 10% more than the actual size of the that you read on the graticule. Whereas if you go to a 78 diopter lens, you have to take off 10% because it tends to make the optic disc look small. Sorry, I've got it around the wrong way. If you've got the 60 diopter lens, the magnification is 0.9, so it means you've got to take off 10%. Whereas if you use a 78 diopter lens, the magnification is actually more because it makes the optic disc look smaller. So you've got to add on about 10%. So what you can do is actually measure the size of the optic disc. And the typical, I don't personally measure the horizontal diameter, but I do tend to measure the vertical diameters in most patients when I first see them. And the average is between 1.6 and 1.9 millimeters. That gives you a ballpark. So if you've got a very small optic disc, you'll probably end up with usually a small cup and vice versa. So here, the optic disc size, the size of the cup varies generally in proportion to the size of the disc. So if you have a small disc, an optic disc which only measures about 1.5 millimeters vertical diameter should almost not have any cup at all. If it has any cup, it's possibly abnormal. Whereas an optic disc that's 2.1 millimeters or greater will almost always have a vertical cup to disc ratio of 0.6 or perhaps 0.7. So it allows you to, if you like, get a gauge in your head of what's potentially normal. So this is a small optic disc, 1.4, and it's got a very small optic cup, perhaps 0.2 compared to 0.6 or 0.5 on this side. This is an even larger optic disc, 2.4 millimeters. Now, Joss Jonas actually did a whole lot of these measurements back in the 1990s, and he's a very good clinical observer, and he noticed that, typically speaking, the inferior neuroretinal rim tended to be the thickest, followed by the superior rim, then followed by the nasal, and then the temporal rim was usually the thinnest. And that he derived the so-called isn't rule, and it's a valuable little mnemonic to have in your head. So if you notice that typically glaucoma, mostly, not always, often starts with loss of the inferior rim. So if you're noticing that the inferior rim is thinner than the superior rim, that's a flag that possibly this patient has got early glaucoma. And also, especially if you start to see excavation or undermining, it's telling you that there's a force acting there that's distorting the tissue, which may be pathological. I'm sorry, I must have moved the slide because the little indicator, oh, sorry, that's the neuroretinal rim inferiorly. And there we go. So you can just get a gauge on the isn't rule, basically. Now, all those points related to what should be normal, here you'll clearly see an abnormality. So there's a notch here, for example, developing, and also the vessels look like they're having to curl around the edge. So there's almost certainly some excavation occurring in this region, whereas looks like there's a nice gentle contour down below inferiorly. Also, this is possibly a disc rim hemorrhage here as well. Here, the notch inferiorly now is much more prominent, and this is definitely worth noting. And there's almost certainly some excavation by the fact that you can see this vein passing along, then it disappears into a cave, and then it comes out again. So that's a very important sign to notice that there's excavation there. If you look very carefully here, you'll see a disc rim hemorrhage on this side as well. Okay, so this patient has got a visual field defect, but it's more of a central field defect, and they've lost nerve tissue, and the disc looks pale. But what you won't see is any excavation. There's no excavation here. So this is not glaucoma. This is something else, perhaps an ischemic optic neuropathy, perhaps a toxic or other sort of optic neuropathy. The other thing to look for, which we probably don't do as much of nowadays, because before OCT scanning, we used to look for nerve fiber layer defect with the red free or the green light, which would light it up. So on the left-hand side, this is a photograph taken with the green light, and it highlights the defect in the nerve fiber layer, which is visible on the color photograph, but it's more prominent on the red free photograph. And it's a useful sign. The OCT scan would definitely pick this up as a focal change, but you can also pick up and appreciate the excavation and the notching here as well. Now, I'm going to show you a few non-standard photographs. This starts to get a little bit more tricky. This is a patient who's a high myope, and normally I would ask one of the registrars to outline where they think the optic disc rim is, and this is a very tricky one. This patient has actually got very small optic discs here and a very large zone of peripapillary atrophy, which is bilateral. These are the visual field defects. You can see on the left, there's quite a marked upper and lower arcuate scotoma. I've magnified this photograph, but it's a bit blurry, so I apologize for that. But I've drawn in where I consider the cup and the disc rim to be. So it's very magnified, but the actual measurement, the vertical disc diameter was only about 1.2 millimeters. And so this cup is actually very large for such a small optic disc and explains the visual field defect. This part here is all peripapillary atrophy. So this is another myope, and you'll notice, for example, that the isn't rule is not obeyed. There's some notching here. There's a disc rim hemorrhage below, and this is the OCT scan. You can see similar features on the sort of black and white or reflectance image, and you'll notice just a little bit of excavation. So the excavation is not marked, but it's definitely present. Now, this is one to really look at. So when you look at this optic disc, I'm sure you're all thinking that looks normal. And sure enough, that's what I thought as well. But when you do the visual field test, the patient had a clear inferior nasal step defect, and the reliability indices were quite good, and we repeated that field test with the same result. So what is going on here? Has the patient got some sort of optic neuropathy, perhaps? Maybe optic disc drusen, for example. This is the OCT scan. And we've scanned through, this is the scan direction here, it's almost vertical. What you'll see is this marked area of nerve fiber layer schisis extending into the optic disc itself. It's unusual. Once you start looking, you will see it. But if you look also at what I think is probably lamina cribrosa, it has gone blown backwards a bit, but the surface of the disc tissue is not in an abnormal position. It's not pushed backwards because of the schisis. The splitting of the tissue has sort of falsely elevated the surface of the prelaminar tissue, and it gives you that false impression that there is no excavation, whereas in fact there is excavation of the underlying lamina cribrosa, which is only visible on OCT scanning. You'll also see the schisis in the focal region on the nerve fiber layer scan on the OCT here. And that gives you a false measurement that the nerve fiber layer thickness is in fact normal when it's clearly not going to be. It's going to be quite abnormal there. So that's, without OCT scanning, I would have been flummoxed. I would have been confused about this particular case. I probably would have investigated for an optic neuropathy, in fact, given the apparent normality of the optic disc on clinical examination. The OCT scan certainly helps. This is another interesting patient. This is patient right eye. It's a stereo photograph. If you want, and you can go cross-eyed and you can fuse those images, and you'll actually see the cupping and the notch inferiorly. I'm doing it right now. I used to get practice doing this when I was a lot younger. And you can also see a disc rim hemorrhage supranasally, and you'll see how the notch matches the visual field. So the cardinal feature of glaucoma is that the optic disc findings should always match the visual fields. And if they don't, then you go hunting for a reason why not. So this is a patient with upper and lower arcuate scotomas on the right and a superior nasal step defect on the left. And here we go. We've got quite marked drusen, what looks like drusen on the right side, difficult to tell on the left. And OCT scanning really clinches the diagnosis. Here you can clearly see these hypo-intense with hyper-intense boundary lumps in the optic nerve tissue in the prelaminar layer, possibly extending towards the laminar zone as well. Interestingly, the nerve fiber layer was relatively normal in this subject. but I think that's to do with how far the ring of examination extended. I realise I've gone too quickly through my talk, but the conclusion is to really assess the neuroretinal rim and to take into account the shape and particularly look for excavation and think about the forces that are being applied to the optic nerve to cause the distortion that you're potentially going to see. And also that OCT scanning can help identify defects in the tissue as well, and the lamina cribrosa and the shape of the optic nerve, as well as the nerve fiber layer loss. Also, then not every scan with nerve fiber layer loss equals glaucoma. So you must identify changes in the optic disc that match glaucoma. So you must look for excavation or typical glaucomatous change. I have seen patients diagnosed with glaucoma who had other forms of optic neuropathy. If the patient is myopic, then that makes it more difficult. And so, again, a careful examination, looking for excavation and other signs is very important. Also, taking into account the size of the optic disc, so measuring the optic disc is very important. I've commented on the OCT scan, and last but not least, I haven't mentioned intraocular pressure at all for making the diagnosis of glaucoma. And I just want to, I'm going to finish by commenting on the very interesting case presentation. And perhaps one of the things you would have noticed on the OCT scans as they were shown was the increasing excavation or depth of the cup on the OCT scan. So that was quite interesting to my mind to see on those patients because they didn't have disc photographs, so it was difficult to see the optic discs there, but the scans were interesting. So I'm going to stop here. I've probably gone too quickly, Verna and Widya. I can, but I think everyone's happy to have an early night, I suspect.
Yeah,
We
but
might have
still,
lots of questions.
Yeah, that's still interesting lecture, Prof. And important to know to all ophthalmologists here. And we have also residents here. And I believe it is understandable and very detailed explanations. And now time for discussions. Is there any question from the participant? I think it's very important. But I saw from the question from chat box, there is one question regarding to the case presentations. Yeah, I think we can discuss about this. Yeah, from Dr. Jonathan Lee. So this interesting case, did this patient get any neuroimaging due to the nasal disc RNFL thinnings? So Dr. Vida, do you have any RNFL disc neuroimagings?
Unfortunately, this patient didn't have any neuroimaging due to the nasal disc RNFL thinning.
Maybe Dr. Firna, can you help Dr. Vida regarding to these patients?
Thank you, Professor. Yes, as actually this patient, if we could see the last OCT examination, there isn't any OCT nasal thinning on the nasal part. So I suspect or I guess that the previous examination maybe not taken very well. So it's a bit like it seems like thinning, but after we do the last examination, actually there isn't any nasal thinning in the OCT examination, Prof. Ike. So we actually didn't do as Dr. Jones asked about the examination of neuroimaging.
Okay, I hope that will be got the answer. Yeah, as we see that from these case presentations, we just short of the fundus photo, yeah, Dr. Firna, yeah. I think we need more photo fundus here for this patient to make sure there is any changes for the optic disc examinations, as Dr. Prof. Morgan have teach us, yeah. So I think it's very important. So maybe is there any questions? Dr. Icha, okay, thank you for a lighting talk, Prof. Morgan. In case of inconsistent Humphrey results, such as earlier case, how do you determine which result is the most reliable? And if we don't have OCT at our practice, how we measure progression of glaucoma through clinical and Humphrey results? So maybe if we don't have OCT, maybe we can use photo fundus, or maybe we can just do with the diagram using, or other thing. What do you think?
Yeah, that's sorry, that's a good question. If you it's very difficult with diagrams. I can perhaps I'll show you. I'm just looking for something to show you actually. Visual fields. Yeah. I'll show you this if you don't mind.
Yeah.
I wasn't sure how long it would, my talk would go for, so I didn't want to make it too long. I think you can see this. So this is a talk I gave quite a long time ago. It's still worth drawing the optic disc, certainly in Australia, is kind of a lost art. It's hard to get people to do a good drawing of the optic disc, but that can help, and you can compare drawings. But obviously, it's best if you do the drawings yourself and you know what kind of errors and biases you have. I'll show you. This is my typical drawing of the optic disc. So here you can see an optic disc with actually a disc rim hemorrhage. So I tend to draw in optic disc rim hemorrhages, and I try and draw the cup and any irregularities in the rim margin as well as the disc margin. And then subsequent visit, sorry, this is the other eye actually. And also where there's what I call shelving, so no excavation, but a sort of gentle rise in the disc surface, I would generally indicate that by these sort of lines here, because we know that it's very difficult to judge where the cup margin ends here. So for future comparison, you can allow some error if you like. So this cup to disc ratio was probably about 0.7. You can actually see some excavation down below, so you can indicate that on your drawing. This is the same patient a couple of years later, and you can actually see, if I flick back and forth, you can actually see a significant change in the neural tissue, particularly in the supranasal region. And you can actually see, a change on the drawing as well. Now, that's probably as good as you can get where you don't have OCT. If you do have a retinal camera, or you can get smartphone adapters these days to take photographs with your smartphone. So perhaps that's worth doing. And then you can compare the photographs. Comparing photographs is definitely a lot better than comparing drawings, but drawings are the sort of next best thing. I used to use this. We used to take stereo disc photographs on slides, and we built our own optical comparator, which would flicker between stereo photographs. So probably Werner saw, and Whittier, you might have seen me do this in the clinic years and years ago. So this is what we used to do before OCT and HRT scanning. This is just an example of photographs. So what you can do with photographs is align them and then look for change. And this is a very subtle change, which you would never pick up by drawing. If you look in this region here inferiorly, and if I flick back and forth, you will actually see that vessel go backwards. And that's a definite change. It's a small change, but it's a definite change. And because there's a little bit of excavation up the top here, it really clinches the diagnosis of glaucoma. There's nothing else that's going to do that. And then you obviously would want to start treatment. But this patient still had a normal visual field. So generally, often you can pick up a change in the optic disc before the visual field changes. Here's another one, a sequence of optic disc photographs. So here, if you look, sorry, I'll go forwards again. If you look to the second image, you can see a little bit of change in the neuroretinal rim, and you also see this disc rim hemorrhage there. But if you flick back, you actually see that there was a disc rim hemorrhage overlying the vessel and extending further into the retina. But it's because you can flicker that you can actually see it. So if you look carefully, you'll see that there's more bearing of that vessel, more loss of tissue superiorly, and also there are actually two disc rim hemorrhages, one on each occasion. So that's one beauty of the photographs. And you can't see disc hemorrhages on an OCT scan or an HRT scan. So that's another reason to look carefully at the optic disc. If you see a disc rim hemorrhage, there's a very high likelihood that the patient has got glaucoma. And if they get frequent disc rim hemorrhages, they're much more likely to progress from their glaucoma. So this is, I looked a lot younger in those days, so I kind of wish I could go back to manually comparing photographs, only because I'd be younger. So we used to do annual dilated optic nerve examinations and annual photography to do a comparison of the photographs. That was the sort of standard. So it's still a very useful technique. One thing, you'll notice that I'm actually holding a stereo viewer at the slit lamp, and I'm comparing with the 60 diopter lens. Interestingly, the magnification of the 60 diopter lens and the stereo viewer is about the same, and you could quickly jump from the stereo photograph to the slit lamp and get a reasonable idea if there was some progression. It's actually a lot faster using OCT scanning these days, and I think that's made me lazier, unfortunately. But yeah, so sorry, that's a very long-winded answer to your question. I hope that helps. In terms of visual field progression, I think that's a whole subject for another talk, which we could easily do.
Yeah, thank you, Prof. Morgans. I think we continue with another questions from Dr. Vidya Andita. Yeah, she has always difficulty in interpreting OCT and examining in myopia patient. Yeah, and can you please give us some tip on that patients and how the ONH appearance on physical examination will correlate with the OCT in myopia patients, and how to interpret it?
Yeah, that's a very big question. I touched on that in my talk. I would probably have to give another talk to really get into that in more detail. I think the bottom line is that the myopic patients tend to not get as much excavation because the optic nerve subarachnoid space is larger and undermines the sclera. And there's a Japanese group led by Onu Matsu, I think her name is, who described this about 5 to 10 years ago. And because of the biomechanical properties, it means that the excavation is less prominent and it's harder to see. So you've actually just got to look harder for it and be more suspicious about glaucoma. The OCT scanning is very helpful actually in this circumstance, particularly if you get I've got a preference. I tend to like the Heidelberg, which unfortunately is more expensive, but the quality of the scans allows you to pick up small degrees of excavation in those particular scans. But yeah, it's just basically being careful with the examination. There's not really any other tricks. And even when you can still miss it. So just having a high index of suspicion and obviously watching the visual fields and the nerve fiber layer measurements. So looking for changes in both the fields and the nerve fiber layer measurements. Now, the trouble with the myopes, the very high myopes, is that the OCT scan metrics are actually often very, very poor. Very hard to get good measurements of the nerve fiber layer tissue, even measurements of the disc tissue with OCT. Photography is actually very helpful in the high myopes. So comparing the photographs, we've got an HRT scanner, which is actually very helpful. It actually has a inbuilt alignment algorithm, so it allows you to flicker, but it's black and white. That's actually quite helpful. But essentially, it's a variation on photography. So if you can take photographs of the myopes and then use them for comparison, sometimes that's more helpful than OCT scanning.
Prof. Morgan, I think I will ask the same questions regarding to the myopic patients. Using the OCT Heidelberg and OCT by Zeiss, do you think is there any differences between this machine?
Yeah, good question. There's almost certainly some differences because there's a lot of mathematics that goes on under the hood that we're not really aware of. But by and large, the shape of the nerve fiber layer thickness measurements are very, very similar. There are some systematic variations, and I'm afraid I'm not up on all the there are people who have been comparing nerve fiber layer measurements between those two devices, but I don't think that matters too much. The Zeiss still gives good measurements of the nerve fiber layer. The Zeiss has got really very nice software for progression judgment, which is easier to use than the Heidelberg. The Heidelberg requires more thought in terms of the interpretation. The Heidelberg's got quite a good flicker mechanism, so you can flick between previous and current scans. That's actually quite helpful, but it's not as easy to use, I think, as the Zeiss. The Zeiss sort of lays it all out for you. So there's pros and cons with both machines, basically. Interestingly, the Zeiss doesn't really give you, I don't think it gives you very good sections through the optic nerve itself.
Optic nerve, yeah.
Whereas the Heidelberg is probably better at that.
Yeah. Okay. I will proceed with another question, yeah, Prof. Yeah. From Dr. Mita. What is your opinion regarding to the pre-perimetric glaucoma diagnosis? Would you consider a pre-perimetric glaucoma when the glaucomatous optic nerve finding is not correlated well with the visual field examinations? Yeah.
Yes, absolutely. Yeah, very much so. I suspect that was probably the case with your own case that we saw, where the disc appeared to be changing on cup to disc ratio measurements. But yes, we see that a lot with definite change on, say, I showed you an example where there was a change on photography with increased excavation, but in that patient, the visual field was still normal, and that's quite commonly seen. And you can these days pick up changes on OCT scanning. The trouble with OCT scanning is that it's, some people will just look at the nerve fiber layer scan and say, yes, it's thinning, but not look at the optic disc to see if there's excavation or typical features of glaucoma. So you run the risk of making the diagnosis of glaucoma when in fact it's an optic neuropathy. So that's a trick to watch out for. You really want to see definite features of glaucoma affecting the optic disc before you label that person as having glaucoma, in my view. But I think that's why I showed that scan of the schisis, because that one had me tricked until I looked at the OCT scan.
Yeah. Okay. Yeah, Dr. Mita, if you satisfied with the answer?
Yes, Prof.
Okay. So, okay, Dr. Ruju. Okay, Dr. Mita, do you have any other questions?
No, I think that's perfectly clear. But if the if the discrepancy between the OCT and the visual field is quite high, Prof, would you still consider it as a pre-parametric, or you would find another cause of the optic nerve abnormality?
Well, I think my previous answer still stands. If the visual, you need to lose between 30 and 50% of the nerve fibers before you get a reproducible visual field defect. So a normal visual field does not exclude glaucoma. Glaucoma is really a diagnosis based on the optic disc examination in that circumstance. So it's excluding other causes of nerve fiber layer loss, like various optic neuropathies, before you land on glaucoma, and looking for excavation and the other clinical signs. It's helpful when you see disc rim hemorrhages. They help to clinch the diagnosis.
Thank you, Prof.
Yeah. There's another question from Dr. Ruju. Yeah, is peripapillary cyst alone is in the absence of philos and disc cupping predictor of future glaucoma risk? Or should this patient be monitored as glaucoma suspect in the absence of other risk feature?
Yeah, that's a very good question. A short answer is I don't know. It's possible. I suspect it possibly is. There have been some reports reporting peripapillary schisis in glaucoma. It seems to be more common in glaucoma. Now, does that mean that you get schisis before you get glaucoma? Well, that's a non sequitur really, but yes, it possibly is, but I don't know for certain. Once I started looking more carefully at the scans through the optic disc, I started to see it a little bit. I do see it not uncommonly. It's not super common, but you will start to see it.
Yeah.
It would be an interesting paper actually. Study.
Yeah. Yeah, the risk factors things here for the glaucoma. Yeah. Okay, so I think from Dr. Fatma Diana, yeah, it's about the myopic patients. Yeah, we have already mentioned about the myopic patient, right, Prof? Yeah, I think we can you talk more about the myopic patients about that? Regarding, it's very difficult, yeah, to see the myopic patient whether there is a glaucoma or not, and then some things that maybe especially whether there is no high IOP, but the cupping look glaucomatous. So what do you think? I think it's very difficult there to see. So how you determine which one is the most important thing, signing this is a glaucoma, or which one is not glaucoma in these myopic patients. So can you tell about this?
Yeah, look, I can't give you a magic formula that you can simply apply, unfortunately.
Yeah.
But the optic, so One thing about the myopes, the really hard myopes are the ones like that one that I showed you with the very small optic disc and the very large sort of circular peripapillary atrophy. So I've shown that slide to a lot of registrars, and they usually outline the optic disc as including the peripapillary atrophy. And once you do that, you think that the optic disc is of normal size and it's just a quirky optic disc. So the first thing is to really identify where is the optic disc, what is it, how large is it, and then really carefully look for the cup and just a small notch or small distinct cup. Well, so when you're looking, if you imagine you're cutting through the optic nerve, most times somebody with glaucoma, you can sort of see definite excavation where it falls backwards and then the cup runs along and it goes up. With a myope, it'll come along and it might just be a short little step and then it goes along. But you will usually see a little step if you look very carefully clinically. And on the good OCT scanning through the nerve, you can often pick that up as well. So I find that helpful. But any myope with a visual field defect, I think be very careful. In my experience, I know people talk about high myopes with tilted optic discs having visual field defects. They're pretty rare, actually. If they have a visual field defect, I think you've got to think about why don't they have glaucoma? What is it? Be very careful about those particular patients. Be careful about the ones who've got a very small optic disc. They notoriously present late. They've often seen various people and that's been missed. And the high myopes or myopes are more likely to have so-called normal pressure glaucoma. It's because their lamina cribrosa is already half the thickness of a normal eye, even when they're normal. So the pressure differential and gradient is twice that of normal, and all those forces are basically magnified. So it puts them at higher risk of getting glaucoma. Again, perhaps that's worthy of another talk, actually. I could show more disc photographs and scans and things. But yeah, that's basically it with you.
Yeah, because we have maybe for the old patients, we have a normal tension glaucoma, and then with the high myopia, and then they have a systemic disease, and it's is it whether this glaucoma or not, and then they have abnormally with the visual field. So I think we have to decide whether this is due to the glaucoma or because of the something in the brain or something like that, maybe in the ION or something like that. So it's very difficult for us to determine which is this a glaucoma or not, something like that. So we have to be careful to see that patient. So we have to make a differential diagnosis for this patient. So I think that we have to consider a lot of things for these patients. Yeah. So okay, I think there is another question from Dr. Nishan Davidos. If the MBO measurements are more reliable than the RNFL measurements for detecting potential progression of their glaucoma.
Yeah, thanks, Nishant.
I don't know. I don't understand BMO. What is BMO measurements?
Yeah, so BMO is a measurement that the Heidelberg machine generates. So not the Zeiss doesn't generate this, but BMO is Brooks membrane opening. So it's where the Brooks membrane ends and the, if you like, optic disc tissue starts. So it basically is measuring the size of the optic disc in a most anatomical way. And that particular scan gives you the thickness of the nerve tissue at the very edge of the optic disc. And it does it in about, I think, 12 locations around the optic disc, and you can get a comparison over time. The short answer is, I don't think it's as reliable as nerve fiber layer measurements for detection of of progression in glaucoma, but it's still useful. With the Heidelberg, with that BMO, so that BMO scan gives you the radial scans through the nerve, which gives you those really beautiful scans that I've just shown you. And you can actually flicker those scans, and you can get more, I think, get more information subjectively when you flicker those scans sometimes. The BMO is a bit crude. It's a singular measurement of each of those scans. Where I think it probably is useful is some high myopes where you can get possibly a better scan in the center of the disc rather than the nerve fiber layer. The nerve fiber layer is often, I don't know what you find, but there's often schisis and other things, foals, other things in the high myopes, and the ring nerve fiber layer measurements are often pretty poor. But in general terms, I think the nerve fiber layer thickness measurements are more accurate for progression. Even those, again, we could talk for a long time about progression judgment measurements, but they're problematic as well. But anyway, I think they're probably the best that we have at the moment. Yeah, thanks very much.
Yeah. So for the BMO measurement, I think what machine that you use, Prof?
That's the Heidelberg engineering.
Yeah,
so
it should be Heidelberg, yeah, because it's very difficult to get with the Zeiss machine, right?
Yes, that's right.
Yeah. Mm-hmm. Yeah. Okay. So I think we have one more questions. I think, yeah, because of the times, yeah. When there is a peripapillary atrophy on the myopic patients with the high IOP, do we suggest that it is a progression to the glaucoma papillary atrophy?
Yeah, good question. There's been a lot of debate about this. So you commonly get peripapillary atrophy in glaucoma. It's more common, especially the so-called beta zone peripapillary atrophy. But it's not really clear whether changes in the peripapillary atrophy mean definite progression of glaucoma. So you'll notice that I didn't really talk about that in the talk. I know it was a very popular subject probably 10 or 15 years ago, but people don't really talk about it now. And I think the main reason is that it's not really very helpful for judging progression. It's a sign of myopia to some extent, and it's a bit more common in glaucoma, but a large proportion of the normal population have got some peripapillary atrophy anyway, so it doesn't help you distinguish between glaucoma and non-glaucoma. And if it changes, it doesn't help you distinguish progression from glaucoma versus just myopic progression. So it's an interesting but probably not terribly helpful sign in relation to glaucoma.
Yeah. Thank you, Prof. I think, yeah, time is...
Well, we've gone over time again, haven't we?
Yeah. I believe we have a very nice discussion today. Yeah. We also learned a lot, but unfortunately, because of the time constraint, we have to finish this meeting, yeah, Prof. Yeah. I think it's 9 o'clock already in your in Perth already, right?
It is. It's late.
Yeah, thank you again, Prof. Morgans, for your important lecture. We always love to hear your lecture, always detailed with meticulous explanations. You have very detailed and yeah. How about Dr. Firna? What's your comment?
Thank you, Prof. It is very interesting, Prof. And actually, in our clinic, we don't have a 60 diopter lens, Prof. We only use 78 and 90 diopter lens. And I found, Prof, when I compare the 90 diopter findings and with the indirect, direct ophthalmoscope, it seems it is a bit different, right, Prof?
Yeah, the 90, I don't particularly like the 90 diopter lens because the image is so small with the optic disc. It's hard to get the detail. The 78 is quite a nice lens. I think you can get enough magnification to get reasonable detail. The 60, though, does give you more magnification, but I think the 78 is quite reasonable. And you just add on 10%, if you like, to the measurements to give you a rough idea of the size of the optic disc with the 78 diopter lens.
Yeah, because when I see with the direct ophthalmoscope, and then I compare with the 90 diopter, it seems like with the 90 diopter it's a bit bigger compared with the direct ophthalmoscope.
Yes, the direct ophthalmoscope magnifies, that's right.
Okay. Thank you. So I learned actually, Professor. Thank you very much for today lecture.
That's a pleasure. Yeah.
Yes. Prof. Should we have a photograph for our meeting?
I'll take my glasses off.
Yeah, so I invite the professor and doctor and all participants to open video, please. Okay, nice. Okay, I'm going to take the screenshot from the first slide. 1, 2, 3. Okay, the next one. 1, 2, 3. Okay, many more videos to come. Yeah, that's all, I think. Prof, doctor, thank you.
Yeah.
Thank you. Thanks very much, everyone.
Yeah, thank you so much, all participants. Thank you for being participate in this evening meeting, and see you for the next meeting. Thank you, Prof. Thank you, everybody.
Thanks. Bye. Bye.
Bye.
Bye.